This content is not designed for use as a medical reference to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, please consult your personal physician.
Hi everyone! In our last two lectures, we talked extensively about Alzheimer's disease, which is the most common form of dementia. There are many other forms of dementia as well, though, and in some ways, they are distinct from both the neuropathology and cognitive deficits observed in Alzheimer's patients. In this lecture, I'd like to take a closer look at three other forms of dementia. We'll start by examining Lewy body disease. This category includes two types of dementia: dementia with Lewy bodies, also known as Lewy body dementia, and Parkinson's disease dementia. We'll then turn to a discussion of vascular dementia. So, do you happen to remember what disorder is associated with the development of Lewy bodies? If you said Parkinson's disease, you are correct. As you may recall, a Lewy body is an abnormal spherical structure found in nerve cells and composed in large part of the alpha-synuclein protein. These Lewy bodies clump together in the brain, which ultimately affects how the brain functions. Lewy body disease is present in both Parkinson's disease dementia and dementia with Lewy bodies. Both types of dementia are characterized by the presence of alpha-synuclein pathology in the following areas: the cerebral cortex, which controls information processing, perception, thought, and language; the limbic system, which plays a role in emotions and behavior; the hippocampus, which is essential to forming new memories; the midbrain and basal ganglia system, which are involved in movement; the brainstem, which regulates sleep and maintains alertness; and the olfactory pathways, which regulate smell. Both of these dementias are grouped together under the category of Lewy body disease because they can't be easily distinguished from each other, either by underlying neuropathology or by symptoms. Lewy body disease tends to occur in individuals over the age of 50 and affects men slightly more than women. In general, the disease lasts an average of 5 to 8 years from diagnosis until death. This time frame is similar to what we see in Alzheimer's disease. Clinically speaking, these two forms of dementia are distinguished from one another based on when they occur. Parkinson's disease dementia occurs in someone who has already been diagnosed with Parkinson's disease, so they are already exhibiting a variety of motor symptoms. Dementia with Lewy bodies, on the other hand, occurs before the movement symptoms of Parkinson's disease or at the same time. There are a few core features of Lewy body disease, including what's known as fluctuating cognition. Here, a patient may exhibit periods of confusion or lack of alertness that comes and goes. 1 minute, the patient may be confused, stare off into space, or speak in a disorganized manner, and the next, they may be perfectly alert and lucid. A second core feature is visual hallucinations. These hallucinations typically involve seeing adults or small children, deceased family members, and small animals, and they tend to come and go. People who have dementia with Lewy bodies may also have delusions, such as of infidelity, house intruders, or theft; misperceptions, like confusing a coat rack for a person, for example, or a false sense of presence or passage, so a sense that someone is nearby when they aren't, or that someone or something is moving off to the side. A third core feature is a rapid eye movement or REM sleep behavior disorder. During REM sleep, our muscles are temporarily paralyzed to prevent our body from moving around as we dream. With REM sleep behavior disorder, this normal paralysis is impaired, leading people to act out their dreams with behaviors such as kicking, punching, and yelling. A fourth core feature is the appearance of one or more cardinal symptoms of Parkinson's disease. So bradykinesia, or slowness of movement, tremor, or rigidity. Other types of motor impairments commonly associated with Parkinson's disease may be present as well. In addition to these core features, patients with Lewy body disease show evidence of dementia. Recall that dementia is a severe loss of thinking abilities that interferes with a person's ability to perform daily activities. Dementia patients tend to have problems with attention, visuospatial abilities, planning, multitasking, problem solving, and reasoning. Unlike patients with Alzheimer's disease, those with Lewy body disease do not exhibit memory problems at first, though these can often arise as the disease progresses. Moreover, the memory issues apparent in Alzheimer's tend to be related to impairments in encoding information, whereas those observed in Lewy body disease are more associated with impairments in retrieving information. Other symptoms include changes in mood and behavior, poor judgment, loss of initiative, confusion about time and place, and difficulty with language and numbers. Additional characteristics of Lewy body disease include sensitivity to antipsychotic medications, falls and/or fainting, problems with autonomic functions, so maintaining blood pressure, incontinence, constipation, and loss of smell, and changes in personality and mood, so depression, apathy, and anxiety. So can you see how Lewy body disease differs from Alzheimer's disease? For one, Alzheimer's is associated with the accumulation of neurofibrillary tangles and amyloid plaques, not Lewy bodies. And even though some of the dementia symptoms are similar, Alzheimer's patients have more prevalent memory problems and do not tend to have fluctuating cognition, visual hallucinations, REM sleep behavior disorder, or cardinal Parkinson's disease symptoms, whereas Lewy body disease patients do. One of the most famous cases of Lewy body disease is that of comedian and actor Robin Williams, who committed suicide in 2014 at the age of 63. 2 years later, his wife, Susan Schneider, published an article in the journal Neurology titled "The Terrorist Inside My Husband's Brain." In this article, she chronicled Robin's symptoms and struggles in the year preceding his death. Beginning in 2013, Robin complained of a variety of symptoms, including insomnia, sleeplessness, heartburn, constipation, urinary difficulty, a slight tremor in his left hand that would come and go, and an impaired sense of smell. Shortly thereafter, he exhibited gut discomfort followed by intense feelings of anxiety and fear. By early 2014, Robin demonstrated symptoms of paranoia, confusion, and difficulty reasoning. In April of 2014, doctors put Robin on antipsychotics, which only made his symptoms worse. It was also during this time that Robin became very frustrated because he could not remember even one line for his scenes in a movie. At that time, he stated that he just wanted to reboot his brain. Finally, in May, Robin was officially diagnosed with Parkinson's disease. By this time, his symptoms had grown to include a weak voice, a parkinsonism mask, a now continuous left tremor, a slow shuffling gait, word-finding difficulties, a frozen stance, visuospatial difficulties, and fluctuating cognition. An autopsy performed upon Robin's death showed that Lewy body disease had ravaged his brain. Specifically, a 40% loss of dopaminergic neurons was noted throughout his brain, and almost no neurons were free of Lewy bodies in his entire brain and brainstem. His dementia progressed quickly and left him in a state of confusion and fear. Robin showed all of the classic symptoms of Lewy body disease except for visual hallucinations. Doctors suspected that he did in fact experience hallucinations, but that he kept that information to himself. So now that you have a better sense of what Lewy body disease is, let's take a moment to clarify the different cognitive effects of dementia with Lewy bodies, Parkinson's disease dementia, and Alzheimer's disease. In 2020, Dennis Smirnov and his colleagues from the University of California, San Diego, published an article in the journal Neurology examining the cognitive impairments and trajectories of these three patient groups. Their study found differences between groups on measures of visuospatial, executive, memory, and language abilities. For all patients, the researchers obtained initial data, then compared it to data obtained in a follow-up assessment 2 years later. They wanted not only to identify differences in symptoms among these three groups, but also to see how patients' abilities declined over time. In the initial measure of visuospatial abilities, the researchers found that patients with Parkinson's disease dementia and those with dementia with Lewy bodies performed at the same level, and that patients in both groups did worse than patients with Alzheimer's disease. The follow-up assessment showed that both groups also exhibited a similar rate of decline in visuospatial abilities, with both outpacing the decline in the Alzheimer's disease group. In regard to executive function abilities, so those skills that enable us to plan and carry out our actions, Parkinson's disease dementia patients performed worse than both dementia with Lewy bodies and Alzheimer's disease patients. The latter two groups exhibited similar impairments. After 2 years, the Parkinson's disease dementia patients showed faster declines in executive function abilities than the dementia with Lewy bodies and the Alzheimer's disease patients. Moreover, the patients with dementia with Lewy bodies showed faster declines than the Alzheimer's disease patients. When examining a variety of memory abilities, the researchers found that Alzheimer's disease patients performed worse than both Parkinson's disease dementia and dementia with Lewy body patients, both on the initial measure and at the 2-year mark. Patients with dementia with Lewy bodies also performed worse than Parkinson's disease dementia patients. All three groups declined at similar rates during this 2-year time period. And finally, for language abilities, no differences between the three groups were identified in the initial measure. At the 2-year mark, Parkinson's disease dementia patients were found to decline at a slower rate than the other two groups. Moreover, patients with dementia with Lewy bodies performed worse than those with Parkinson's disease dementia. So, what do these findings mean? Well, we can conclude that on some measures, Parkinson's disease dementia and dementia with Lewy bodies patients performed similarly to each other, and both groups performed worse than Alzheimer's disease patients. Analyses suggest that executive function is more compromised in Parkinson's disease dementia, while memory and language abilities are more compromised in dementia with Lewy bodies. Moreover, These findings suggest that Alzheimer's disease patients exhibit more deficits in memory abilities, whereas Parkinson's disease dementia and dementia with Lewy bodies patients exhibit more deficits in visuospatial and executive function abilities. Now that we've talked about Lewy body disease, let's now turn our attention to another form of dementia, known as vascular dementia. Vascular dementia results from damage to blood vessels in the brain, which reduces their ability to supply oxygen and nutrients that allow the brain to function effectively. This disorder is hard to diagnose because it's not tied to a single cause, but has many different causes and clinical manifestations. As you know from our lectures on stroke, we have large and small arteries and vessels in the brain that supply oxygen and nutrients to both cortical and subcortical brain regions. Vascular dementia looks different depending on which area of the brain is directly affected. For the purposes of this lecture, I'm going to divide vascular dementia into three categories: cortical, subcortical, and mixed. In general, cortical vascular dementia, which affects the gray matter in the brain, has a relatively abrupt onset, days to weeks. A stepwise deterioration, meaning you'll see some recovery after symptoms worsen. A fluctuating course, so cognitive function will look different across days. And mild cognitive symptoms like episodic memory impairment and possibly aphasia, agnosia, and visuospatial difficulty, depending on the specific arteries involved. Some degree of executive dysfunction may also be present. Cortical vascular dementia is likeliest to occur either due to an accumulation of dead brain tissue caused by inadequate blood supply to a region, known as infarcts, or following a major stroke. It is the culminating effect of someone having a series of small strokes over a period of time. Dementia is more likely to result if the resulting strokes affect both sides of the brain. The underlying cause of cortical vascular dementia is typically atherosclerosis. If you recall from our stroke lectures, this is a disease of the arteries that is characterized by plaque buildup on the inner walls. This buildup occurs due to hypertension, high cholesterol, high levels of fat and triglycerides, smoking, and diabetes. It generally affects medium to large size arteries and is often implicated in a variety of different types of strokes. Atherosclerotic plaques are prone to break off, and the resulting blood clot can travel up to the smaller arterial branches in the brain, causing a blockage. Sometimes these small strokes can be clinically silent, meaning the affected person shows no symptoms, or symptoms may be temporary, lasting just a few minutes because the blockage clears itself. If symptoms last less than 24 hours, then the blockage is identified as a transient ischemic attack, or TIA. If the blood supply is interrupted for more than a few minutes, even if the stroke is clinically silent, the stroke will lead to the death of a small area of tissue in the brain, creating an infarct. The accumulation of these small infarcts or lesions over a period of time can result in cortical vascular dementia. Cognitive symptoms associated with cortical vascular dementia will vary depending on the specific brain areas affected. Some more common symptoms include confusion or problems with short-term memory, or getting lost in familiar places, walking with rapid shuffling steps, loss of bladder or bowel control, inappropriate laughing or crying, difficulty following instructions, and problems making monetary transactions. Occurrence of a major stroke, generally from large vessel disease, can also result in cortical vascular dementia. Recall from previous lectures that the carotid artery travels up our neck and eventually branches off into three main arteries that supply blood to our brain. These arteries include the anterior cerebral, middle cerebral, and posterior cerebral arteries. These large arteries in turn divide into smaller branches as they travel throughout the brain. A stroke occurring as a result of large vessel disease interrupts the blood flow in one of the main arteries in the brain. Blockage of one of the large arteries also cuts off the blood supply to all of the smaller arteries that branch off of it. Typically, this blockage is caused by a blood clot that travels from elsewhere in the body, called an embolus, getting lodged. These clots usually originate in the heart, but can travel from a carotid artery or from some other distant vessel in the body. By contrast, a clot that forms within a blood vessel rather than traveling there is known as a thrombus. Most strokes that occur as a result of large vessel disease are embolic ones, so due to a traveling blood clot. And an embolic blood clot is more likely to get stuck in a large vessel if the inner lining of the artery is damaged due to atherosclerosis. Following a major stroke, about 25% of patients develop some form of vascular dementia within 3 months. Although my mom was not officially diagnosed with vascular post-stroke dementia, she certainly displayed many of the associated symptoms. In hindsight, it seems strange that after a person suffers from a major stroke, it is normal for us to just assume that as days and weeks pass, they will get progressively better. With post-stroke dementia, it's actually the opposite that happens. Right after the stroke, the person is more alert and higher functioning than they will be in the weeks and months that follow. Even though you psychologically think that the person is recovering, what you don't realize is that as the brain tries to repair itself, many more neurons have since died, leaving lesions in the brain that will affect the person's ability to function. Even though my mom was severely impaired immediately following her stroke, she was more like the mom I knew than she would be 3 months later, when she appeared physically better, yet cognitively worse. Now let's move on to our second subcategory of vascular dementia, subcortical vascular dementia, which affects the white matter in the brain. This kind of dementia has a more variable presentation than the cortical kind. In fact, there appears to be no consistent pattern of symptom onset or progression. Clinically, it is characterized by a subcortical cognitive syndrome with primary deficits in executive functions and speed of information processing, and secondary deficits in episodic memory. Memory impairment is less striking in subcortical vascular dementia than in Alzheimer's disease. It is characterized by impaired recall, relatively intact recognition, less severe forgetfulness, and a greater benefit from cues. However, mood symptoms such as depression, anxiety, and emotional lability are more frequent and persistent in vascular dementia than in Alzheimer's disease. Other symptoms may include bradyphrenia, gait abnormalities, urinary incontinence, and parkinsonism. Subcortical vascular dementia is most likely to occur due to small vessel disease. Small vessel disease refers to an assortment of abnormalities that occur in the small blood vessels of the brain, resulting in changes to white matter. Examples of small vessel disease include lacunar infarcts, which are multiple small infarcts resulting from occlusion of the small penetrating branches of a major cerebral vessel. The infarcted brain tissue softens and decays, leaving small cavities in the brain, typically 2 to 15 millimeters in diameter, white matter hyperintensities, which can be seen on MRI imaging, indicating that some type of white matter changes have occurred, and there tend to be cerebral microbleeds, which means that minor bleeding has occurred in the brain from a leakage in a small blood vessel. It's important to note that white matter lesions occur as a result of normal aging. In imaging samples of patients aged 65 and older, at least 30% showed silent infarcts on brain imaging scans, and up to 90% have varying degrees of white matter lesions. So just because white matter lesions may be detected on an MRI scan does not mean a person is in danger or has dementia. I mean, honestly, if everyone who was asymptomatic had a brain scan, we'd find all sorts of strange stuff. As a funny side note, and something I briefly mentioned back in the stroke lectures, the day after my brain aneurysm surgery, the doctors performed an MRI scan so that they could see the coiled aneurysm to make sure it looked okay, and to see if I experienced any other changes in my brain as a result of the surgery. They uploaded my MRI report to the patient portal, and of course, I made the mistake of reading it. It referenced the presence of the coil, which was good, but then it talked about an evolving infarct in my right frontal lobe and changes in my subcortical white matter. It totally freaked me out, and so I immediately called my neurosurgeon, and he indicated to me that this was normal. As he put it, I was manipulating the major arteries in your brain, and you were on blood thinners at the time, which can cause small bleeds to occur. What you were seeing is post-surgery trauma to the brain, and these changes you were seeing on the MRI tend to resolve themselves over a period of months. This made me feel a lot better, and I am not noticing any type of frontal lobe deficits, so I think I'm good. But it just goes to show that you should not freak out if you read an MRI report, as it's not written from a clinical perspective. It is merely observational. Had the report said something to the effect of, "We are seeing these brain changes as a result of the surgery, but they don't mean anything," I wouldn't have panicked. Our third category is mixed dementia, which consists of cortical and subcortical vascular pathology. With mixed dementia, physical pathology representing more than one type of dementia occurs simultaneously in the brain. The most common mixed dementia is Alzheimer's disease, where one sees amyloid plaques and neurofibrillary tangles, combined with vascular dementia. The second most common mixed dementia is a combination of Alzheimer's disease and dementia with Lewy bodies. As I've already mentioned, some type of vascular pathology is evident as we age. In some individuals, this pathology can contribute to other degenerative disorders and lead to dementia. Some argue that vascular dementia alone rarely counts for a pure vascular dementia, except for cases of large strokes, and that the vascular pathology is contributing to overall impairment rather than being the principal cause. Autopsy studies suggest that most people over the age of 80 who have dementia most likely have a mixed dementia. Moreover, at least 1 out of 10 people diagnosed with dementia is diagnosed as having more than one type. Before wrapping up this lecture, a word on vascular cognitive impairment, an umbrella term for cognitive loss before it advances beyond effective treatment. Patients with vascular cognitive impairment are usually better able to function day to day than those with vascular dementia. Like vascular dementia, vascular cognitive impairment occurs due to a variety of vascular causes and etiologies. Several organizations have included diagnostic criteria for vascular cognitive impairment, including the American Heart Association, or AHA, the Diagnostic and Statistical Manual of Mental Disorders, or DSM-5, and the International Society of Vascular Behavioral and Cognitive Disorders, so VASCOG. The risk of progression from vascular cognitive impairment to vascular dementia is estimated at 50% over a period of 5 years. So, how do you think you can best protect yourself against getting vascular cognitive impairment or vascular dementia? By now, the answer should be clear. Keep your blood pressure and cholesterol in check, maintain a normal weight, exercise. If you smoke, stop. And if you have diabetes or atrial fibrillation, keep them under control. The more you take care of yourself and live a healthy lifestyle, the lower your risk for developing any type of vascular pathology as you age. Okay, that does it for today's lecture on Lewy body disease and vascular dementia. We'll continue our discussion of dementia next time as we examine frontotemporal dementia and Wernicke-Korsakoff syndrome. See you then.